Good day and welcome to the Who, What, When, and Why regarding CAR T-cell therapy conference call. Today's conference is being recorded. At this time, I'd like to turn the conference over to Jennifer Gillette. Please go ahead.
Thank you, Melinda. Yes, my name is Jennifer Gillette, and I'm the staff social worker at the National Bone Marrow Transplant LINK. I'd like to welcome everyone on our call here today. This month's program will focus on CAR T-cell therapy. A special thank you to our sponsors for today's program, the Leukemia and Lymphoma Society, Insight Corporation, Pharmacyclics and Janssen, and Bristol Myers Squibb, as well as the O'Mara Corporation. We also thank our esteemed LINK partners for today. Just so everyone knows how the call will be going, first, I'll have just a couple minutes introducing what the National Bone Marrow Transplant LINK does, just in case anyone's not aware of us. Then I will introduce you to Dr. David G. Maloney, who is the Professor of Clinical Research Division, Medical Director of Cellular Immunotherapy at Fred Hutchinson Cancer Center. And then we have a survivor speaker, Kristin Kleinhofer, a leukemia survivor, who will share her personal experience and details regarding her success with CAR T-cell therapy. And then we'll open the floor for pre-submitted questions and live questions. I will let everyone know today that we received an abundance of questions, and we're certainly going to try to get to as many as we can, but we will not be able to address everything during the hour, but it will be a very action-packed hour. And then we'll just have our closing. So for those of you who may not be familiar with the LINK, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are our webinars, our podcasts, our blogs, our lunch and learn calls like the one you're on today, and we have a variety of topics such as chronic graft versus host disease or disease-specific information, caregiving, coping, treatment options, and survivorship after a transplant. We have a content-packed Facebook page with daily inspiration, relevant tips, and breaking news. We also have our peer support mentor program for patients, caregivers, and donors. We have our second birthdays recognition programs, because after transplant, you deserve 2 birthdays. And then we have books and referrals, and we provide emotional support from a licensed social worker. So if you need more support on your journey, please feel free to reach out to us. And also, before we begin today's program, just a couple housekeeping items. Please be mindful in being concise with your questions so that we may answer as many as possible on the call today. Also, know that the information provided in this program is meant to stimulate conversation with your own healthcare provider and is not meant to replace your individualized medical plan. So now, on to the educational part of our program. We are so very thankful to have our first speaker with us here today, Dr. David G. Maloney. He, as I stated earlier, is a professor. He's a medical director. He's endowed chair for clinical research at Fred Hutchinson Cancer Center, and he's at the University of Washington. But Dr. Maloney, basically, he just comes packed full of knowledge on CAR T. He received his MD and PhD in cancer biology from Stanford University. He completed his internship and residency in internal medicine at Brigham Women's Hospital and a fellowship in oncology at Stanford. He joined the faculties of Fred Hutchinson Cancer Center in the University of Washington in 1994. Dr. Maloney's research interest is in the development of immunotherapies for lymphoma, myeloma, CLL, and ALL. He has had a long-standing interest in the mechanisms of action of monoclonal antibodies and the use of the non-myeloablative allogeneic transplantation for the treatment of hematologic malignancies. He has also, for much of his career, has focused on developing and improving antibody-based therapies against blood cancers. He was instrumental in the development and testing of rituximab while working with Dr. Ron Levy at Stanford. Rituximab was one of the first antibody-based cancer drugs on the market, and it transformed the treatment of certain leukemias and lymphomas. Currently, Dr. Maloney's major interests are in the development of the chimeric antigen receptor, or CAR T cell therapy, for which he leads multiple clinical trials using this therapy for a variety of cancers. Dr. Maloney has amassed greater than 265 publications in peer-reviewed journals in the areas of research described above. In 1993, the Society for the Biological Therapy, now the Society for Immunotherapy of Cancer, conferred on Dr. Maloney as its presidential award. His care and commitment to patients is routinely acknowledged, most recently over the last 5 years when Dr. Maloney was included in Newsweek's Top Cancer Doctors, the Castle-Connolly Guide, America's Top Doctors for Cancer, and named by his peers as a top doctor in medical oncology, Seattle Magazine. Without further ado, thank you so much for joining us, Dr. Maloney.
Well, thank you very much. It's my pleasure to be with you today, and I apologize up front that my voice is not very good. I'm getting over a bit of a cold here. So what I'd like to start off with is maybe 10 to maybe 15 minutes of just some explanation of what CAR T cells are to get everybody on the same page. And then I'll be looking forward to addressing questions if I haven't covered them in this kind of brief introduction. So first of all, what are we talking about when we talk about CAR T cells? Well, to start, you really need to know what is a T cell. So T cells are part of your immune system, and they're the part of the immune system that actually patrols for virally infected cells or in some cases cancer cells. And normally we have billions and billions of different T cells in our blood, and they're just essentially waiting to see if you get an infection with a T cell that has experienced that before. And then if that happens, those T cells then expand and control the infection by killing the virally infected cells, and in some cases potentially killing cancer cells. Now, people have really been enamored with the idea of using T cells to treat cancer, but the problem is it's like finding a needle in a haystack. If you try to find the T cells that are actually trying to potentially kill the cancer cells, it's almost impossible. There are some approaches, though, that are recently gaining traction, and that's called TIL cells, where tumor-infiltrating lymphocytes, where they can be taken out from tumors and essentially the T cells isolated and expanded and then given back to patients. And this can work in some types of cancers. But the real breakthrough came with the development of what are called CAR T cells. And so the idea is that we take out normal T cells, and again, remember, those are against billions of different things, but we then make them essentially universal. And the way that it's done is that the T cells are taken to a lab and they're modified, usually using a virus, and there's a couple of different types of viruses that can be used, that carries a new piece of genetic material or DNA that can modify the normal T cell to now express a receptor. The way I like to think about this is that receptor is like a piece of Velcro, and it's specific for its other half of Velcro, but it doesn't really bind to anything else. And so the idea is you put this specific receptor in all of the T cells, and then when you give those T cells back to the patient, they patrol around, and if they find the opposite half, the thing they can bind to, then they bind to those cells, and that in this case that's the tumor cell, and that triggers the T cell to be activated, to grow, and then to essentially kill whatever it has bound to strongly. And so the advantage here is that the T cells can be modified, and now instead of 1 in a billion, you actually have most of your T cells that we have taken out, we have modified, and then we give them back to you. Now, it's obviously only still a proportion of your T cells, but those T cells then can actually grow, divide, and get after the cancer. And in the hematologic malignancies, such as ALL and lymphoma and myeloma, this has turned out to be a remarkable treatment. And because of this, there have been multiple products approved by the FDA, and we'll talk about those. So now I want to transition that's what it is. Now, how is it actually done? So to get CAR T cells, patients usually have to be evaluated at a treatment center. And this is a pretty complicated process, so it's not going to be done widely in community small-based hospitals. It requires treatment at either a transplant center, which is where many of these studies are done, or in specialized centers that have developed CAR T cell therapy. And patients have to be evaluated for their general function, their organ function, heart, lungs, liver, kidneys, make sure everything is okay to be able to go forward and withstand the vigors of the treatment. And they're usually evaluated for how much lymphoma or leukemia they have, and that usually requires scans and bone marrow biopsies or lumbar punctures, depending on the nature of the disease. And then after this, if this is okay, then the cells are collected by a process called apheresis. And this is a simple process, relatively simple process, where blood is taken out of one arm and run through a machine and put back in the other arm, and the cells that contain your T cells are actually collected. This takes about 3 or 4 hours and usually only requires once. Sometimes it requires a catheter that's put either in the chest or the neck if the arm veins are not good enough. The risks are pretty minimal, and we do this, in fact, with normal people who are donating platelets, for example. These cells then are collected, and there's no chemotherapy involved in getting the cells collected, or there's no growth factor involved. It can be done really as long as you've recovered from your recent treatments. The cells are then sent off for manufacture, either to the center or to one of the companies that makes the CAR T cells. This generally takes 3 to 5 weeks. And, there is some risk with this. I mean, by risk, I mean that sometimes it can't be done. Sometimes the cells don't grow. Sometimes the manufacturer fails, and we're forced to consider restarting again. But generally, the cells then come back to us around 3 to 5 weeks later, and they're in a frozen state, and they can be frozen in essentially liquid nitrogen and kept for as long as necessary before the treatment. Now, the actual treatment starts off with usually 3 days of chemotherapy. This is relatively light chemotherapy compared to what people are usually used to for these types of diseases, but it's 3 days and it's almost always with drugs called fludarabine and cyclophosphamide. This has some side effects from chemotherapy. It can drop your blood counts and cause some nausea, but generally this is fairly well tolerated. And a couple of days after that chemotherapy, so around day 5, the cells are then infused. And the cells are infused, they're thawed out, and then they're infused from directly through a catheter in either your arm or the chest or neck, depending on whether you have a indwelling catheter, and these cells are infused. Now, this is where this treatment becomes totally different than anything else that's kind of out there. These are living cells, and these cells will essentially double, if we're lucky, about every day. So if we infuse X number of cells, then tomorrow you have twice as many, the next day 4 times as many, the next day 8 times as many, next day 16 times as many. So you can see in 3 or 4 days, you now have 10 times more cells than we infused. And another 3 or 4 days, you have 100 times more. And another 3 or 4 days, now you have 1,000 times more cells growing in your body, going after the cancer. And these cells will grow and expand as long as there's cells that express the target. And this generally happens over a couple of weeks. And so when these cells are, again, this is unlike chemotherapy, these are living cells that will persist, expand, and grow and multiply. So as they're doing this, they can then produce toxicities, which are the key things that you need to consider. But as these cells grow, they don't grow forever. They grow until essentially they've eliminated the cancer or cells with the target, and then they contract back down. Just like a viral in a viral infection, your cells would grow until you clear the virus, and then the cells will contract back down and hopefully provide a bit of memory in case you encounter that virus again. So when these cells are growing and expanding over those 2 weeks or so, they can produce toxicities. And there's two specific types of toxicity that are a hallmark of CAR T cells. The first one is called cytokine release syndrome, or CRS, and people like to describe that as a very bad flu. And it has many of the manifestations of a bad flu. People can have very high fevers, aches and pains, low blood pressure, sometimes difficulty breathing. And this is usually moderate to mild, and it can resolve in 3 or 4 days, but very rarely can be very, very serious and can result in people being in an ICU or needing even to be on a ventilator or having blood pressure support medications. Now, again, that's relatively rare, but it certainly can happen. This is likely due to the fact that the CAR T cells, as they're expanding, are producing a bunch of substances that are called cytokines, and those cytokines are really what are responsible for making you feel really lousy when you have, for example, a bad viral infection or bacterial infection. Many of your symptoms are caused by the T cells going after that virus. And this usually resolves in a few days to a few weeks in kind of the worst cases. Now, a second toxicity, which is really quite unusual and had not been really described before, is called neurologic toxicity. And this appears to be from a leaky blood-brain barrier. And normally, many of these substances in your blood are kept out of your brain by something called a blood-brain barrier. And when people have severe cytokine release syndrome or these high levels of cytokines, it appears that some patients have a leaky blood-brain barrier, and some of these compounds can get into the brain and actually cause people to have toxicity. And the toxicity is usually related to people having problems with understanding what's going on. They can't respond appropriately, can't answer questions, sometimes can't talk. And in rare cases, this can be more serious. People can have seizures or even look like they're in a coma. And this can be very, very serious, and very rarely patients can end up in the ICU and rarely die from complications of neurologic toxicity. Both CRS can be treated, and we have treatments that can treat and in some ways maybe prevent some of cytokine release syndrome. Neurologic toxicity is treated usually with steroids, such as dexamethasone, and usually again resolves in a few days. So the most exciting time after CAR T cells is generally within the first couple of weeks, when people can develop cytokine release syndrome or neurologic toxicity. And the rate of what this toxicity, how it happens, really is instrumental in deciding how the patients can be treated. So, for example, some CAR T cell products, the onset of CRS and neurotoxicity is more delayed, closer to 5 to 8 days. And so often these patients can be treated in the outpatient setting and then only admitted if they get toxicity, whereas other CAR T cell products, such as axicabtagene ciloleucel or Axicel or Yescarta, happens within the first 24 hours in most patients. And so there's really no sense in trying to treat them in the outpatient setting, as virtually everyone gets some toxicity and needs to be in the hospital. But once you get through weather this first couple weeks, then patients get usually sent back to the outpatient setting around a month after treatment. Most patients have had their blood counts recover, but some still are needing transfusions. Most of the time, CRS and neurologic toxicity is resolved, and we're usually interested in restaging the lymphoma or leukemia at that time. And frankly, what we see is that many patients are in complete remission at that point, and so that's the best possible outcome at that point. We restage patients with the scans they had before and biopsies that were informative from before. So this is usually done in that around 4 weeks, and then patients are sent back to their home or wherever they've been referred in. So that's just a whirlwind tour of what the treatment is. And it's really important to understand these general toxicities. Now, who do we treat? Well, we now have multiple agents commercially approved, and this is in acute lymphoblastic leukemia, or ALL, and there have been 2 products approved for pediatric and young adult, and then also for adult ALL. and that's tisagenlecleucel or Kymriah for the pediatric young adult, and then brexucabtagene aldelucil or Tecartus for adults. And the treatment scheme is exactly like I mentioned above, but this would be then for patients with ALL. And then we have 3 products approved for aggressive lymphomas. This is tisagenlecleucel or Kymriah, axicabtagene ciloleucel or Yescarta or Axicel, and then lisocabtagene marrowleucel or Lysocel. And those 3 products are approved for relapsed refractory aggressive lymphomas and have very high response rates and again, excellent results for just like as in ALL, we have very high remission rates, and some patients appear to be long-term probably cured from these treatments. And then in follicular lymphoma, Axicel is approved in that setting, and it's also approved in mantle cell using a slightly different variation, again called Tecartus. Now, the exciting thing is that these studies all start off in relapsed and refractory patients. So these are patients who have failed all kinds of standard treatments, so standard therapy, failed treatments where actually I should say the treatment failed the patient. The patients didn't fail the treatment. The treatment failed the patients, including bone marrow transplants. And that's where these studies started, and that's where the initial FDA approvals were. But as of just earlier this year, CAR T cells have been studied in first relapsed diffuse large B-cell lymphoma or aggressive lymphoma, and there were 2 trials recently reported at the end of last year, and both studies, 2 studies were positive, and axicabtagene ciloleucel was FDA approved to now be used in the first frontline setting. So in that study, patients were randomized between going straight to CAR T cells versus going down the path of trying to go to an autologous transplant. And so the CAR T cells ended up being better. They ended up having better outcomes with more patients in remission and less subsequent therapy. So this is extremely exciting as we're moving CAR T cells up in the treatment. And this is just an example of what we expect to happen in the future, where these treatments will be moving forward in all of these diseases I've talked about. Now, I didn't mention multiple myeloma, but multiple myeloma, we have now 2 CAR T cells approved as well in the relapse and refractory setting. That's Abecma and Carvecti, and these have also shown very exciting responses in patients with multiple myeloma. So that's a whirlwind tour of just a little bit about where we're at in CAR T cells and what they are. Obviously, we need to follow patients longer to determine whether these treatments are curative or whether we need to consider other therapies in patients. We do need to monitor for long-term complications because these treatments often can be immunosuppressive, and they can block the patient's immune system from responding to other infections. And obviously, in the setting of a pandemic, that can be very serious. So we need to monitor immunoglobulin levels in most patients, and sometimes patients need IVIG treatment to help protect their immune systems and have them recover. And some patients still have trouble with their blood counts recovering. This is often a complication of the prior treatment that the patient has had as well, which can make the bone marrow reserves low. So I'm going to stop there, and I'll look forward to answering questions. Thank you very much.
Thank you so much, Doctor. You have quite the gift of taking some very complicated data and making it very understandable. So thank you so much. Great information. I also would like to introduce now our next speaker, Kristin Kleinhofer. Dr. Maloney was actually her CAR T doctor and principal investigator for the clinical trial she was enrolled in at Fred Hutchinson Cancer Center when she received her CAR T cells in November 2014. Kristin's going to share her experience as a leukemia survivor, her journey through clinical trials, and being in remission from this disease for 7 years. Thanks so much for joining us, Kristin.
Thank you. I'm so excited to be here and to share my journey of a life that was saved by CAR T cell therapy. So for me, my cancer journey, it really began 12 years ago in 2010. I had just turned 36 and I was enjoying life, and I had no physical symptoms with the exception of a small lump I found on top of my head, with everyone just thinking it was a harmless cyst that needed to be removed. However, it wasn't, and I was diagnosed with the aggressive blood cancer, acute lymphoblastic leukemia. So I quickly, after educating myself on my type of cancer and seeking a second opinion and unloading my life and taking a leave of absence from work, I went ahead and entered the hospital, and I began the 2-year standard protocol, which is intense chemotherapy regimen, hyper-CVAD. And that chemotherapy protocol, it was successful, and it was able to get me into remission for the next 1.5 years. And although it had appeared that the treatment had been successful, my aggressive cancer did return in February 2014, and it had even morphed with a new chromosome abnormality. And I discovered a lump on my neck is how I discovered it. And so once again, I had to unload my life, and I began inpatient salvage chemotherapy. But it wasn't working, and the cancer was growing, and it was tripling. And I remember at that time, I decided to really choose a mantra to help carry me forward. And it's a quote by Christopher Reeve, and it says, "Once you choose hope, anything is possible." And that mantra really carried me forward from then to today. And so because I had exhausted all standard treatments, I began to seek clinical trials for options for treatment. And it wasn't only because I was fighting for my own life, but I really wanted to help further cancer research so that I could help other cancer patients. And so I was fortunate to learn from my oncologist that a nearby academic center was having an open clinical trial for adults with relapsed or refractory acute lymphoblastic leukemia, and it was using a combination of different chemotherapies. And so I went ahead and enrolled in that clinical trial, and it was a 4-week inpatient clinical trial. And the plan was to try to get into remission so that I could pursue a blood or marrow transplant in the future. And it did get me into a temporary remission, but it wreaked havoc on my body. And it was really during this time that my medical team started to bring up CAR T-cell immunotherapy as a possible next step. And it was 2014, and there wasn't a lot of information like there is today, and we did not know what it was at all. And so it was really my mom at the time that did the research, and we were so excited with the information that she found, as it made so much sense using my own immune system to fight my cancer, as I was being left with toxic side effects from chemotherapy, and my cancer was obviously becoming very resistant. And so I told my oncologist I wanted to pursue that. And so at that time, amazingly, because it was so fresh and new, there were only about 3 clinical trials that I would have been eligible for at that time. And so my oncologist reached out to those 3 clinical trials, and I was so fortunate that Fred Hutch was willing to meet with me. And so in May 2014, my mom and I flew to Seattle from California, where we live, and we met with Dr. Maloney, who's here today. And he was the principal investigator for the CAR T clinical trial. And he thoroughly informed us on the clinical trial, the benefits, the potential risks, the common side effects, and some of his success stories. And based on that information, I knew I wanted to pursue. And so we did further testing while I was out there. And then, as Dr. Maloney had mentioned, my white blood cells, in particular my T cells, were collected via apheresis, and it was about a 4-hour period. And then those T cells were sent to the Fred Hutch lab, and they were genetically engineered to recognize the cancer target marker CD19 on my type of cancer, grown in the millions, and they were frozen for future use. Shortly after we returned to California, I was informed that I didn't qualify for the CAR T clinical trial at that time, as no evidence of cancer had been found in the testing that had been done. I was still in remission from the previous clinical trial. And so, of course, I was very disappointed because we really felt that immunotherapy was the next step in my journey. But as expected, the little pesky leukemia, it returned for the 3rd time a few months later. And so our hope was that CAR T was now that viable option. And was so fortunate that Fred Hutch did go ahead and accept me. And so in November 2014, my mom and I flew to Seattle and I enrolled as an early patient because it was 2014. I believe I was patient 13 with acute lymphoblastic leukemia in the CAR T clinical trial. And to prepare the body for the CAR T cell infusion, I did undergo a few days of outpatient chemotherapy. Back then it was 6 days, but nowadays it's only 3. And then the big day for me was November 19th, and that's when I received my CAR T cell infusion. And I remember it was just such an exciting day, and we were just so full of hope. We were sporting our Choose Hope t-shirts, which reflected my mantra, and it was my partner, Benny, and my mother. And I remember my CAR T cells arriving in a cooler and my cells being put on the IV pole. And I was looking at this magical, powerful, life-saving bag. And it was amazing to see that this little, powerful little bag, it looked clear like saline solution, could be something that could save my life. And it was an exciting time. I was one of the first outpatient patients at that time. And Dr. Maloney came over to check in on me, and other medical staff were so excited, and we were taking a lot of photographs. And I remember Dr. Maloney saying, we don't know when, you might start a reaction. It could be any time from the day of infusion to a few weeks out. And so we were sent home. That night, I actually ended up spiking a fever. So I got admitted to the hospital. It ended up just being a reaction to the infusion of the CAR T cells. So once the fever passed, I was released. And then about the 4th day after my infusion is when I experienced the anticipated cytokine release syndrome, which, as Dr. Maloney had said, is an inflammatory response of the re-engineered T cells going around and attacking my cancer. And I remember at that time, I was envisioning little Pac-Mans going around and eating up my cancer because, of course, I'm a child that grew up in the 80s. And so I was admitted to the hospital during that time, and it was about 6 days. And I experienced a lot of the common side effects that were very much like a bad body flu. I had high fevers of over 102. I had body chills, muscle aches. I had heavy night sweats. I had to constantly change my hospital gown at night. I had some slight mental fogginess, kind of like chemo brain, just kind of a little bit slower function, slower thinking. I had low blood pressure, so we were keeping an eye on that. And then, of course, I had low blood counts because I had just gone through the chemotherapy prior. And so we were doing Neupogen injections and blood transfusions. And it was also the week of Thanksgiving when I got my CAR T cells. And I remember my mom bringing in a home-cooked meal for us to share. And we were really giving thanks for receiving this novel therapy. And once these side effects passed, I was released to outpatient monitoring. And a little over a week after my hospital release, so it was about 3 weeks after the CAR T cell infusion, I did spike a fever again. And so I was readmitted to the hospital for a few days, and it ended up that I had contracted 2 blood bacterial infections. So I was given antibiotics. And it was also during this time that we did the bone marrow biopsy to check on the CAR T cell infusion and the treatment to see how it worked. And we were just so excited. We learned that no evidence of cancer was found, and it was just truly amazing. I remember just really a month after my CAR T cell infusion, I physically felt so strong, unlike any other chemotherapy regimen I had undergone before. And I just felt like it was just a treatment that just didn't compare to anything else I had, and I could really snap back into my life so much quicker. I did learn as well that my CAR T cell therapy with the bone marrow biopsy had worked so well that I had a side effect called B-cell aplasia, in which case it not only killed my cancer B cells, but also my healthy B cells. And so we were just keeping an eye on that in case I needed IVIG infusions in the future. And it was really exciting to be part of the early success stories of CAR T cell in my clinical trial and to know it was working well for others as well. And now for me, it was the recommendation of my medical team at Fred Hutch and then also in California that given my high-risk cancer, that I do proceed with a blood or marrow transplant as the next step in my cancer journey. and that was to give me an increased chance for continued survivorship. And my mom and I agreed, and I did not have a bone marrow match on the registry or within my family. So I was fortunate to learn from Dr. Maloney that there was a clinical trial that was also taking place at Fred Hutch, and it was using cord blood as the donor source for my stem cell transplant. And so I met with the clinical trial principal investigator, and then in about January 2015, I went ahead and enrolled in that clinical trial and began my transplant journey. And my transplant was in February 4th, 2015, and it was successful. And that brings us to today, where I am now celebrating 7 years of remission with no evidence of disease. So it's really, really exciting. And I'm just really very passionate now about really paying it forward through my patient advocacy efforts, sharing my message of hope, and mentoring fellow cancer patients and caregivers as they navigate their journeys. And as many of you on this phone call can imagine, it really takes a village to get through cancer journeys. And I know that I couldn't have done it without my strong support system of my family and friends, my two amazing, amazing caregivers, my mother and my partner, Benny, who are by my side every day, 24/7, and then my amazing medical team, which includes the Fred Hutch team with Dr. Maloney, who all work together for my survivorship. And it's really an exciting time right now. It's blown up, since I even received it in 2014 with the 6 FDA approvals. And it's just exciting as more discoveries are made and more things are perfected as we're looking at more cancers and looking at different cancer targets. And it's really giving us patients hope when they've exhausted all treatment options, such as myself and others. And it's really offering the possible gift of more time for many. And I also really like that it's less toxic and it's more targeted therapy. And it truly is changing the cancer treatment landscape. And I'm truly hopeful that one day it's going to be a frontline therapy where I wouldn't have had to go through all that I went through before I got it. And I really want to thank you, Dr. Maloney, and all your colleagues on behalf of all us cancer patients for really working together to fight cancer. You are really changing and saving lives. And I am living proof of how far the CAR T-cell research and results that were envisioned could be. Thank you.
Wow, Kristin, what a beautiful story. I thank you so much. It's such a privilege to hear it. And kudos to the whole team at Fred Hutch. They're absolutely amazing. And Dr. Maloney, we thank you. At this time, we're going to start the question portion. I'm going to ask a couple questions of Dr. Maloney from some of our pre-submitted, and then we'll also try to make time for some live questions. But the first question, Dr. Maloney, is if remission ends, when during that time is the best time to receive treatment? Is CAR T-cell treatment only used after multiple relapses?
Yeah, that's a great question. But first, I want to just thank Kristin for her comments. Those are very, very kind, and I really want to thank her for participating in that clinical trial back in 2014. We were just learning about how to do this, and there were virtually no options for treating adults with ALL at that time. And so obviously we've learned a lot since that time, when we now have commercial approval. So that's exciting. As I mentioned, CAR T cells it's an evolving field. Right now, the majority of CAR T-cell products are approved for patients who've had to have had multiple prior treatments. So, for example, for an aggressive lymphoma patient, you have the initial treatments are very good, and often we can cure patients with the frontline treatments such as R-CHOP or chemotherapy like that. But if it comes back after that, especially if it comes back within a year or so, CAR T-cells are now becoming an option with oxycaptogene ciloleucel, or Yescarta, which is now approved in that setting. And that was based on a study called ZUMA-7, and that study randomized patients who had first relapse of aggressive lymphoma randomize them to go get additional chemotherapy and an autologous stem cell transplant, which is our standard of care, which has been proven in previous studies. That would be one arm, and then the other arm was to go straight to CAR T cells without having to get additional chemotherapy. And the results of those studies showed that actually CAR T cells were better, and that and in part that's because many patients don't get to transplant because the chemotherapy doesn't work. So to answer your question, right now, if you have an aggressive lymphoma, then you can get to CAR T cells after the first relapse of primary chemotherapy and don't have to wait as long until third or fourth relapse. For other treatments, it's still 2 or 3 lines of treatment in general, but it takes time to move these treatments up a line of therapy, and so those studies are being done now, and there's discussion, as Kristin mentioned, about trying to use CAR T cells earlier and even frontline after initial doses of chemotherapy in some diseases. So it's a really disease specific, but good question.
Great, thank you. Another writer asks, is there waiting list for treatment? Is it accessible enough that people can get it once they do meet the criteria?
Yeah, that's another great question, and it really depends on where you live. The challenge with this treatment is that it's technically complex and it does take a while. So the average length of stay at a center to do CAR T cells is probably close to 3 months. And that's counting a week or so for evaluation, getting the cells collected, 3 to 4 week period of waiting for the cells to be manufactured, and then about 5 weeks of the actual treatment. So the challenging part is having to essentially relocate close to a treatment center, and generally patients need to stay within about 30 minutes of the treatment center during this period of time once the CAR T cells have been infused. And so that's really, there are some logistical hurdles. Centers are somewhat busy, manufacturers are busy. There's a bit of a backlog in trying to get these products made and get dates to have them produced. So there are some dances that have to be done. The key thing is trying to get involved in a center as soon as possible if it looks like that's going to be a potential treatment option. So, in patients with aggressive lymphomas, if you relapse, then I think the first thing you should be doing is be talking to your doctor about how to get to a CAR T cell treatment center.
Okay, great, thank you. The next one is, are there clinical trials occurring for CAR T in the earlier stages of treatment, and who qualifies for those? I know you talked a little bit about that already, but can you speak to that any further?
Yeah, there are some clinical trials that are ongoing, and there's some that'll be starting. So, for example, there was a study done with axi-cel or axicaptogene sialucil, Yescarta. Again, that was done in people treated with initial chemotherapy. So they got 2 cycles of chemotherapy and then had a PET scan. If that PET scan was positive, they went straight to CAR T cells. And the results of this small trial look very, very encouraging, and this will likely lead to another trial that'll be done in that setting for patients with high-risk disease. So the usual requirements for this is you have to fulfill the entrance criteria for the study, and it depends on what the study is, but in this particular setting, it'll require very high-risk lymphoma where we don't think that standard treatment options are very good and that there's a very high chance of relapse with the standard treatments. And so those are the typical rules. There also does have to be some basic organ function. Your heart, lungs, liver, kidneys have to be generally working so that we can feel assured that you can make it through the toxicity.
And I'll give you one more before we start opening it up to callers. Is there any side effects or quality of life issues specific to CAR T cell therapy that survivors would need to be aware of beyond the CRS?
Well, CRS and neurotoxicity, generally those symptoms are resolved. Sometimes there can be some neurologic issues that can hang on or take a little bit of time to resolve, but generally they do. I mean, frankly, I see that mostly the post-treatment period is dominated on whether your lymphoma stays in remission or not. And people who stay in remission, they generally have pretty good quality of life that seems to improve over time. Obviously, if your disease relapses, then you're subject to getting additional treatments. And unfortunately, just because you get a CAR T cell doesn't guarantee you're going to have a good outcome or be cured. But in many diseases, this leads to the highest rates of remission we've ever seen, and a sizable fraction of those patients are in remission 2 to 5 years later, leading us to think that they may be cured. The major issues, as I mentioned, are immunodeficiency and the risk of infections. We're still very concerned about the risk of COVID infections. We do try to revaccinate patients after they have CAR T cells, just like we do after a bone marrow transplant. And patients usually get revaccinated against the common childhood vaccines that they received as well, to try to prevent the increased risk of infection that can happen after CAR T cells.
Thank you so much. Melinda, can you tell our callers how to ask questions?
Certainly. If you'd like to ask a question, please signal by pressing star 1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Again, press star 1 to ask a question, and we will go right into our first signal. Please go ahead. Your line is open.
Hi. Am I being heard?
You sure are.
Oh, great. I had a CAR T a year ago, March, and I've been a great success story from that for DLBCL, for lymphoma. My question is about B-cell aplasia that happens after CAR T. So in other words, when all the B cells are killed and not just the cancerous B cells. I'm living with that right now, and I rarely hear any information about how to live with that and whether or not there's been any regrowth of B cells, and specifically what risks and safety precautions I should take.
Yeah, that's a great question, and that's what I was talking about of the immunodeficiency that can happen after CAR T cells. Now, the reason this happens is because the target of the CAR T cells is something called CD19, and CD19 is on normal B cells and it's on the tumor B cells, because the malignancy, diffuse large B cell lymphoma, comes from your normal B cells, and it's a malignant clone of your normal B cells. And so if we target CD19, there's no way of avoiding killing the normal B cells. But that's the same thing that Rituxan does, for example. It kills them on something called CD20. And we know that in people who get rituximab, which everybody does, their B cells are wiped out for at least a year or longer just from Rituxan. So CAR T cells are no different, and they can wipe out the normal B cells as they're growing and emerging, as long as the T cells are present. So this is where we don't know all of the information yet. In general, if you look at people, their CAR T cells don't last forever. And if you watch over time, the CAR T cell count goes down in the blood and they eventually go away. They either get immunologically rejected or not. And then if that happens, if the CAR T cells are no longer present, then the normal B cells can start to recover, and at some point you can get normal B cells to start to come back, and that can lessen the risk of not being able to respond to vaccines or get infections. The usual treatment for this is IVIG, and patients who have low IgG levels after CAR T cells should be getting IVIG on an every couple of month basis, and if their levels are low. And this can greatly decrease the risk of infections such as sinusitis and ear infections, etc. So that's generally what we recommend. The only way to monitor this is to look for B cell recovery in the blood, which usually takes a year or two potentially, and it won't really happen as long as the CAR T cells are present at this point. But most of the time the CAR T cells eventually go away, and most patients will have evidence of B cell recovery starting after about a year or so.
Okay, and the CAR T cell count can be tested?
You don't usually need to test the CAR T cell count. You just look for B cells. If you don't have any,
you look for B cell recovery.
B cells, right? And if you don't have B cell recovery, then you presume still have CAR T cells.
Okay, thank you very much.
Do we have another
caller?
We do.
Yes, we do. We move into our next caller. Please go ahead. Your line is open. And you may have your mute function on. Please go ahead.
Oh, sorry. My husband was diagnosed with multiple myeloma in January, and he's been going through chemotherapy with an eye towards a stem cell transplant coming up in June or July. Should we talk to his doctor about CAR T as the first option, or do they pretty much insist that you go through the bone marrow transplant first, or are the results better with CAR T for this disease?
Yeah, that's a great question. We don't have any answers yet. And so there's two products approved. There's two products approved for multiple myeloma. They both require that you've either been through 3 or 4 prior rounds of treatment. And so there's no FDA approval for patients in their first treatment. Now, that said, there are some clinical trials ongoing in various parts of the country, and the best place to go look at that is clinicaltrials.gov and just look for clinical trials. But there is some interest in trying to get clinical trials where people would get several rounds of standard chemotherapy and then consider getting CAR T cells. But there's zero evidence that that would be better at this point than getting the standard approach. Our standard approach is to get people into the best response and then to do high-dose therapy and an autologous stem cell transplant, and that's proven to be the best approach so far, but we have no studies yet randomizing patients, for example, between that and CAR T cells, and that's going to take 5 years before we're going to have outcomes of those kinds of trials, and they haven't even started yet. So it's a bit too early to say that CAR T cells are going to be better than transplant in myeloma, but we'll wait and see. So at this point, unless there is a clinical trial available, you need to, my recommendation would be to stay on the standard line therapy, and we know that autologous transplants are beneficial in that setting.
Okay, thank you.
We can take our next call.
We do move into our next question. Please go ahead. Your line is open.
Hi. I'm about 90 days, 100 days post-CAR T, and I had a very bad cough after CAR T, which was treated with everything but the kitchen sink, and as the symptoms are under control now, but I feel still a rasp. And I found out anecdotally from others on a CAR T Facebook group that they are also experiencing some type of a cough after CAR T. And I was wondering if there's any kind of studies or if you've heard anything about it.
No, it's not a common thing. I mean, certainly if anything I see in that situation, I'd be more concerned that there's some kind of an infection or bronchitis. And it depends on your exact situation. If patients have been through a transplant, for example, then that can be even a more serious situation. But I'm not aware of any major things with cough. That's not recognized. I mean, it can certainly happen, but I'd be mostly concerned that it's some undiagnosed viral infection or even bacterial infection. And as patients are very, very immunosuppressed in the post-CAR T cell setting, you need to be really, really careful about infections. And, some of these infections take very long period of time to resolve, unfortunately, and especially COVID. COVID is very, very serious in patients who who have had CAR T cells, and we've had several deaths of patients from COVID in the long-term follow-up periods, and that's very upsetting when that happens and someone's cured of their malignancy and ends up dying of COVID. So you need to take infections very, very seriously. Need to be given IVIG if your IgG levels are low, and antibiotics or antivirals if necessary. But in general, we would investigate that pretty seriously with a bronchoscopy and see if we can figure out what's going on.
Thanks.
We do move into our next question or comment. Please go ahead. Your line is open.
Doctor, I have marginal zone lymphoma. Is CAR T therapy being used for that?
Yeah, that's a great question. It was included in a study called ZUMA-5, and ZUMA-5 was a study of low-grade lymphoma treated with axi-captogene sialucil or Yescarta or Axi-cel. That study included a small number of patients. I think it was around 30 patients with marginal zone lymphoma. The results are actually quite good, but when that was looked at by the FDA did not approve Axi-cel to be used in marginal zone lymphoma. It approved it for follicular lymphoma. So right now there is no easy access to commercial CAR T cells, but the results look pretty good, maybe not quite as good as follicular lymphoma. So the other option is to get into clinical trials, and there are several ongoing clinical trials. We have one, for example, with the CD20 CAR, that we're treating patients with marginal zone lymphoma at the Fred Hutch, but other centers throughout the country are also doing clinical trials against other targets, CD19, CD20, or CD22 in these lymphomas. But right now, there is not a commercially approved CAR T cell for patients with marginal zone lymphoma. Hopefully that'll change.
Thank you.
We do move on to our next question or comment. Please go ahead. Your line is open.
Yes. So there appears to be two different drugs for follicular non-Hodgkin's and for the more aggressive transformative version. How would that work? Do you do CAR T on transformative cancers, hematoma?
Yeah, so that's great. Another really good question. So there's one drug approved right now for follicular lymphoma, and that's Axi-cel is approved, or Yescarta, axi-captogene sialucil is approved for follicular lymphoma, and tisagenlecleucel, or from Novartis, is at the FDA right now, and it's anticipated that will likely get approved sometime in the next weeks to months. And so that would be two products available for follicular lymphoma. There's actually three products available for follicular lymphoma that is transformed into diffuse large B-cell lymphoma, and that's the tisagenlecleucel, the Axi-cel, and then the Lysocel or lysocaptogene marrow. All three of those are approved for patients who have transformed to diffuse large B-cell lymphoma from an underlying follicular lymphoma. Now, the Lysocel can actually be used for transformed large cell lymphoma that has come from other things other than follicular lymphoma as well, and can also be used in patients with CNS involvement of their lymphoma, where the other ones don't have that in their label. So there are quite a few approaches, and the results, I think, look quite good for transformed disease, especially with axi-captogene sialucil and with Lysocel.
Okay.
Good
and
question.
if it's transformative, would you have to go through the 3 rounds of standard chemotherapy, or would you be able to jump the line, so to speak?
Yeah. Well, it kind of depends on what you were treated for before, and so that's a really complicated question.
Follicular. Okay.
If you've been treated for the follicular lymphoma before and then you relapse and it's transformed, then we usually want people to be treated at least with one good attempt for the transformed lymphoma, because that can often be cured with standard treatments such as R-CHOP in many situations. And so if that didn't work, then most patients would be eligible for CAR T cells.
Okay, thank you.
Thank you. We'll take one more question.
Please go ahead. Your line is open.
Hi. My wife has primary plasma cell leukemia. This disease does not ever seem to be addressed in any trials or in the possibility of CAR T cell treatment, and she is now on our 5th regime.
Well, yeah, that's a tough question. I mean, yeah, that's a really tough issue, and many of the clinical trials in myeloma have excluded plasma cell leukemia. And so those are just determinations that were made from the clinical trials. I don't think it's a great thing to do, but many of the drug companies are trying to come up with a more uniform, patient set so they can get the best data possible to be able to present to the FDA and hopefully get approvals. I'm not aware of any clinical trials that are focused on plasma cell leukemia. But again, I go to clinicaltrials.gov and look and see whether there's any CAR T-cell trials there. You certainly, I don't think patients with plasma cell leukemia are completely excluded from the commercial agents. It really depends on whether you can get insurance approval for it. And I would definitely check with local CAR T centers wherever you're at to see whether they would have an opportunity to get you into one of those
Well, she's on a waiting list.
Yeah, that's the problem.
She's on a waiting list with Charlotte and Dr. Voorhees.
Yeah, well, that's the problem right now with multiple myeloma is that the companies are not able to keep pace with the demand, and there are many, many, many myeloma patients waiting on waiting lists to try to get the next available manufacturing slots. The problem is not the centers. The problem is actually the manufacturing capabilities of the companies involved, and they're not able to produce enough patients at a time to meet the current demand. And this is really very, very unfortunate at this point. And it's one of my major headaches is trying to advocate for getting more slots for patients to be able to be treated.
Thank you so much.
Thank you.
One more quick one for you, Dr. Maloney. Our Canadian friends are wondering if you know if it's going to be in Canada anytime in the future.
Well, that's an impossible question for me to answer. Yes, I think some CAR T cells will be in Canada, and I think they're already starting. There's some clinical trials ongoing, I know, in the Vancouver group, and I think in Toronto as well. So there are CAR T cell trials going on, and I think that, yes, there will be some, but again, the medical system there is quite different than the United States in terms of how they approve drugs, and I'm unable to really answer that question.
Okay. Well, I just want to thank you, sir, for an amazing presentation today. I am sure everyone is grateful for all you shared. And Kristin, I also thank you again. You certainly brought all of this home to the personal experience behind this. And we thank everyone for joining us on this call. We thank our sponsors and our LINK partners. Without you, we wouldn't be able to make these programs possible. And we hope that everyone has a wonderful day.